Okay, and we'll get things rolling. All right, everybody. All right, everyone should be able to see this. Welcome to our bi-weekly lecture, everyone. This is GOME. If it's your first time, we host lectures every other week focused on topics in wilderness medicine. So our mission is to create an educational platform where interested students and healthcare professionals can explore and interact with various topics in wilderness and emergency medicine. We also aim to showcase the diverse spheres in which physicians and healthcare professionals can make an impact and inspire others to think abstractly about the really cool ways we can utilize our careers in this profession. And we also like to create a community with all the speakers we host and all of our attendees. And we aim to keep promoting a diverse and culturally competent environment. So if you haven't already, feel free to follow us on one of our many social media handles. We also have a YouTube channel now. Here's a QR code with more information. Stay tuned. In addition to lectures, we offer information about fellowships, certification, and other cool things like that. Here's some pictures of our wonderful e-board and some more of us. All right. And just to show you everyone the schedule for the rest of the semester, we are currently on April 10th. We have 2 more lectures. So stay tuned for more great talks. So today's speaker is Dr. Venkat Reddy. In 2000, he graduated from the University of Queensland with his doctorate in medicine. And soon after, he completed his master's in public health, also in Queensland in 2005. He worked as an ophthalmologist for a few years before becoming a fellow at the Pacific Eye Institute in Fiji. Over the next few years, he participated in numerous eye camps in rural regions in Fiji and India, including some efforts as a cyclone relief operation co-leader also in Fiji. He is currently a lecturer and educator at the University of Queensland, and somehow he finds time to also be a part-time PhD candidate where he is studying the healthcare systems of Nepal. So Dr. Reddy certainly has a very interesting career on paper, and I am very excited to hear more about his career. So with that, I will stop sharing my screen, and Dr. Reddy, the floor is yours.
Thank you, Nate. Can you see that screen?
I can see it.
Beautiful. Thank you very much. Thank you, Nate, for that wonderful introduction. And what a wonderful organization GOME is from what I've seen and what I've experienced so far. Thank you for inviting me. It's really quite a privilege for me to be addressing this audience of medical students and interested healthcare professionals. I'm told that this is your first lecture in ophthalmology. I hope it won't be the last, and I hope it plants the seed for further exploration and learning, not just in ophthalmology, but in other areas of medicine and healthcare, in wilderness settings, in rural, what we'd call in Australia here, rural and remote settings. This slide here was taken from the front of a ship. I'm not a very ship savvy kind of guy. The front of the ship, I don't know whether that's called a bow or something, but when we were just docking onto an island in Fiji called Ovalau to do a medical camp there. And for me, this is quite significant, because between me, where I'm standing, and where we're going to practice medicine, where we're going to tend to the sick and try to help them, is a bit of ocean. And that's to remind me and remind us all that really this is a journey from where we are and where we'd like to be to help the people that we would like to help. And so we're all on this journey together. I've, traversed some of it. You have traversed some of it, and you will hopefully traverse more of it. You will cover more of it and make your life a life of serving. I'd like to acknowledge the traditional owners and the custodianship of the lands on which we meet, whether we're here in Australia or in the US or anywhere else in the world. There was always somebody there, in my case at least, somebody there who was there before me, who looked after things, who took care of things so that I could come along and make my contribution to society and express myself. And so I'd like to acknowledge them. And I'd like to pay my respects to their ancestors and their descendants who continue cultural and spiritual connections to country, to this earth and to the ocean, to the waterways and to the mountains. We recognize their valuable contributions to Australian and global society. In this case, global really does have an underline under it. This is a bit of artwork on the right called the Brisbane River, of the Brisbane River by some artists called Casey Coolwell and Kyra Mactello. So this is the brief I've received from your leaders, from your board. I think we're most interested in hearing more about your experiences in practicing rural medicine in Fiji and India and the path that brought you there. I certainly hope to share some of that path. Nate has chalked out some of it with his introduction, and I'll go a little bit more into that shortly. And as mentioned, this is also the first lecture in the series related to ophthalmology. So we are very eager to hear, or we are eager to hear about pathology and treatment considerations when practicing in a rural or remote environment. And I will cover that more towards the end of the talk. Now, I'd like to also urge you, if there's anything that you don't understand, any comment that you want to make, please unmute yourself and just speak directly into the mic. That way I can hear you rather than me having to look at the chat. I'll be asking some questions, maybe, just to get you interested in the area. And so if you feel up to it, please again, just unmute yourself and just shout out the answer, and we can have a bit more fun with this rather than me just talking the whole time. And so I'll tell you a little bit about myself and what were my inspirations. This speaks to the path that I took to get to where I am. So my inspirations during medical school, and then I'll provide a very broad overview of the global burden of vision impairment. My area of interest, I suppose, or my area of work predominantly has been the Pacific in Fiji. And so I'll talk a little bit, I'll drill down a little bit more into that before considering some of the things which are behind or which are underneath, which lurk beneath the epidemiology, which are the inequities of vision impairment and eye health access, before going into the barriers to accessing eye care in Fiji. Now, these things are these discussions will be had from my point of view in the context of Fiji, but a lot of these things apply, a lot of these factors are in force elsewhere in low and middle income countries, in rural and remote settings. I'll then share my own personal observations about the challenges of eye health care. And again, these are to some extent generalizable, and you won't really know that until you're in that setting and you've had a bit of experience. But the purpose of this lecture really is to kind of open your eyes, pun intended, open your eyes to some of these other considerations so that we can make informed choices about our careers. We can have insights and hindsights, like in my case, of the landscape of high health care that is out there in settings like Fiji. And then towards the end, I will share with you what I learned, some of the key lessons that I learned in this career so far, before concluding with where's the hope? Because you might think, well, by the time I hope it's not the case, but you may think, gosh, it's also overwhelming, it's also daunting. Where is the hope? So as Nate said, this is a little summary of where I am, and I'm just of where I've come from. And I'd just like to highlight a few things which are there in bold. And the first is that in my master's thesis, I was born in Fiji and raised there. And I came to Australia to do high school, and then went to New Zealand to do my first degree and then going to medical school in Queensland and came over here. And so my background really, I've had low and middle income countries, those populations which are in some ways disadvantaged to have access to, or barriers to the access to healthcare, in my heart from the get-go, from the beginning. And so for my master's thesis, I did a project based on the indigenous populations in Cape York, which is as far north of Queensland as you could go. And after that, it becomes Papua New Guinea, which is a different country. So I was looking at eye health in Aboriginal communities there, in 11 Aboriginal communities in the Cape York. And then, as Nate mentioned, in 2015, I worked as the Ophthalmology Fellow for an organization called Fred Hollows New Zealand in Fiji, and it was a clinical and teaching role. I've also done numerous eye camps in rural Fiji and in India. And that's both informed my view. I see Tamika Bell has just entered the waiting room. Tamika, welcome. You're a familiar name to me. And it's just wonderful to see your name pop up there on my screen. And you may have heard some of this before, Tamika, and I hope that it reminds you of some of the things that we discussed when you were here in Australia. And as Nate mentioned, again, cyclone relief work, Fiji, unfortunately, is quite vulnerable to cyclones. And I've done a bit of relief work there. And the last one, the biggest cyclone that ever hit Fiji, was a Category 5 cyclone Winston. We call them cyclones. You might call them hurricanes or typhoons. I'm not really sure what the meteorological differences or nuances are between them, but I just call them cyclones. And right now, my PhD on the side is assessing the climate resilience of the Nepal health system. The thread that you might see through these bolded words is that there's been an interest in my heart and my mind in rural and remote settings in low and middle income countries. And so I've tried to take every opportunity I could that presented itself, and sometimes I've sought them out to actually work in those areas. And my life's been enriched by it. I hope to share some of that with you today. When I was in medical school, I visited this place. It's called the Sri Satyasai Institute of Higher Medical Sciences. And it's in a tiny little village in Andhra Pradesh in India. And this building just looks so incongruous. It stands out from the landscape because it's a little village and not very good access. Of course, now the access is much better. Before I went into medical school, I actually visited this place and I was absolutely blown away by it. Absolutely blown away. There is no cash counter, or there's no payment counter. Every bit of service that's rendered in this hospital is absolutely free. Whether you're a multi-billionaire, and some people come from outside, from other countries because of the healthcare provided in this place. Whether you're a billionaire or a pauper, you will get, and I don't use that term pejoratively, I use it almost poetically to say the extremes of society, the extremes of the world are treated here free of charge. And there are lots of people there to help, volunteers, and everywhere you look, smiling, there's just care and attention. And at the same time, providing world's best care to whoever comes through the door. I was really impressed and deeply touched by this. And I thought, when I practice medicine, I want to practice like this wherever I am. And I used to have on my desk, on my study desk, in fact, the desk I'm sitting at today is the very desk I used all the way through medical school. My mum came and bought me this desk when I first moved into medical school. You know how parents kind of come in and try and sometimes come and help you get settled in and set up. So my mum went and bought me some furniture. I had nothing in my little apartment. And she bought me this desk. And on this desk, I had a laminated picture of this. And I would look at it every day and say, that's what I want to end up with. So that was my goal. That was my kind of motivation. And my other motivation, in medical school, I came across this book called Fred Hollows, The Autobiography. And it's about an eye surgeon who was born in New Zealand, trained in Australia and in the UK, and came back to work in rural and remote Australia predominantly, Professor Fred Hollows. And he did a lot of work with Indigenous communities in Australia at a time when it wasn't very popular. And, to do that sort of work, there was a great burden of disease. And yet The access to healthcare for Indigenous people was very poor. He then went on to serve and set up institutions in places like Eritrea and Vietnam. And after he passed away, there was a foundation set up in his name by his wife and others, and it's a big organization now. And I was blessed, lucky enough to work for Fred Hollow's New Zealand, the New Zealand branch of that, for a year in 2015. So he was an inspiration to me. I thought he faced a lot of obstacles and barriers himself, but he just pushed through because his objective was to serve the sick and needy wherever they were, in the most remote parts of Australia or in other countries. And this is what Professor Hollow said, and I hope you can catch the words underneath the very thick Australian-New Zealand accent here.
Serve. Because the whole tradition of medicine is going to the sick and tending to the sick. It's no good being a smart doctor if you're all the time out on your kiwi fruit farm outside Te Puke or wherever they grow kiwi fruit these days. And that's one of the great drags of medicine, you know. You have to get up in the middle of the night. You have to tend to the sick when they're sick, not just when it happens to be convenient to you.
So those are the sorts of words that really fired me up and motivated me through medicine. It made me think that the environment that I'm actually training in medical school and that I'm going to be working in, it's very well resourced. And there's some status associated with medicine. Some doctors are very well paid. But what Professor Hollow gave me was a view, an insight into the very essence of medicine, which is to tend to the sick, which is, to put it simply, to help people. After that, you know, when I was working in ophthalmology, these realities of the global burden of disease, of vision care, or vision disease, or eye disease, I started to appreciate them more firsthand. And I've put some studies and some research findings here and some statistics in here. Really, the reason for that is to put some firm basis, to add a platform of facts to my own experiences of practicing eye health in rural and remote settings, particularly in Fiji. Did you know, for example, that there are 2.2 billion people, and this is dated data a few years ago, who have vision impairment, and about half of them have vision impairment that could be prevented or is unmet, their needs are unmet. And out of that, refractive error is a large component of that. Anybody know, you want to shout out the different kinds of refractive error that you might know about? What are the different kinds of refractive error? Any thoughts? Oh, there are many kinds, aren't there? Myopia, presbyopia, hyperopia or hypermetropia, and astigmatism is there as well. And the bulk of this unmet need is in refractive error and unaddressed presbyopia. For want of a simple pair of reading glasses, a lot of people in the world are struggling. And this has been my experience. So this is from a paper by Williams et al., that this affects near vision tasks. So print and small objects, mobile phone use, sewing, weaving, and preparing lentils, rice grains were ranked most difficult. And when I went to these rural and remote settings via the eye camps that I joined, one of the common complaints used to be, you know, when you ask the patient for the presenting complaint, they'd say, "Oh, can't read the Bible," or "can't pick the stones or the pebbles out of rice," because they would sort rice manually and they can't see it. Latterly, I suppose, when cell phones became a bit more prominent and a bit more common, can't see the writing on the cell phones. Cataract also is huge. And what's the treatment for cataract is an operation, really. We don't know of any other definitive treatments. Glaucoma, any idea what glaucoma is? Have you met that condition before or heard of it before? Yeah. Oh, good, Sam. Yes, strabismus. Oh, sorry, I didn't see the chat box there. Like I said, feel free to just unmute yourself and shout it out because I may not see the chat box. Strabismus is not really a type of refractive error, Ani. That's a good thought. It's more a misalignment of the eyes, so that they might be off to one side or both of them. Yes, and Sam, you're right. All those conditions that you mentioned are absolutely correct. Any thoughts on what glaucoma is?
Tamika says, is it raised intraocular pressure? And
Yes,
that makes
Tamika?
me remember that there's open and closed angle things. And I want to say that's a glaucoma. Is that correct?
I think you're both on the right track. There's a little bit more nuance to that, Tamika. Raised intraocular pressure is a risk factor for what we call primary open glaucoma or other forms of glaucoma. There is a form of glaucoma called normal tension or normal pressure glaucoma, where the intraocular pressure is plumb normal, sitting right normal, and yet we have glaucoma. And as Anne says, you're getting very warm there, Anne, very close. Optic nerve disease. Actually, it's when the optic nerve is damaged that we officially, we call it glaucoma. Having said that, we use that term a bit loosely, as we do a lot of other terms in medicine. So yeah, between yourself, Tamika, Nate, and Anne, I think we're getting there. So it's raised intraocular pressure is a risk factor, but when optic nerve is damaged and visual field is affected, we call that glaucoma. Corneal opacities. So that's the clear window at the front of your eye, which is responsible for 2/3 of the focusing power of your eyes is the cornea. And so why might you think you might get an opacity? An opacity is just the way that we use it in English. It's something you can't see through. Why might you get a little patch in your cornea, which is meant to be crystal clear, perfectly smooth, absolute. It's a beautiful, pristine surface, the cornea. I'll tell you what, it's one of the most beautiful things you're ever going to see. If you look at the microscopy of it, this beautiful, pristine structure, it has sometimes can get opacities. Why might you? Yep, trachoma, ulcers, tuberculosis, Sam, spot on. Diabetic retinopathy. What are the different kinds of diabetic retinopathy? Yep, Peters anomaly, all of those things. Perfect, yep. Diabetic retinopathy, why might you get that? Or not why might you get it, but what are the different kinds of diabetic retinopathy that we've heard about? So it's retinopathy, in other words, the retina is affected, and diabetic, it is caused by diabetes. Could be type 1, could be type 2 diabetes, or insulin dependent, non-insulin dependent, however you want to categorize it. What are the different kinds of diabetic retinopathy? Any thoughts? Well, I like to think of it like Goldilocks, the porridge that she found. I don't know if you have that children's story that's common in America, but the Goldilocks story of she goes and finds, porridge which is cold, or too hot, or just right. And the bed she finds is either too hard, too soft, or just right. So diabetic retinopathy, generally speaking, just as simple terms, 3 forms: mild, moderate, and severe. And then you get proliferative non-diabetic retinopathy rather as well. So these are the different kinds of eye diseases that are seen around the world. So what about in the Pacific? Well, what has been found is that those causes of global eye disease are reflected in the Pacific and places like Fiji: cataract, uncorrected refractive error, glaucoma, corneal disease, and AMD is on the rise as people are living longer. Any idea what AMD stands for, or ARMD? Sometimes people say that. We'll write it as that. It's age-related macular degeneration. So the damage is at the macula, which is right in the middle of the retina and is responsible for your central vision. When I'm speaking to you here and I'm trying to look at the, yeah, that's right, Tamika, well done. Agree-related macular degeneration. I'm happy to have people agreeing with me. And when I'm trying to read this screen and trying to read Tamika's message, or Nate's message to me, I'm using my central vision. And so that is the responsibility of the macula. And we get age-related changes. There's no rocket science there. It is age-related. Everybody who gets to a certain age, beyond that, they're at higher risk of AMD. Interestingly, it was found that trachoma was on the decline. And that's largely due to the work done by people like Professor Fred Hollows, whom I mentioned earlier. Trachoma is a disease, a bacterial condition that affects the eyes that is related to poor sanitation, a lot of people living in close proximity to each other, not having access to hand hygiene, for example. So as the standards of living and as the drivers of this disease have become known and public health measures have been taken to address them, the incidence and prevalence of trachoma has been reducing. And it's thought that in many places in the world, Southeast Asia and in the Pacific, it will be a non-entity. Probably the figures are lagging now, but once we do that epidemiology, I think we'll find that that it's pretty much a non-entity. And this has been confirmed by other studies by people like Ramke et al. Now, a condition that we haven't talked about so far is here, pterygium, in the bottom row of the blue box on the right. Any idea what pterygium is?
That's like sun exposure causes like a thickening of like the sclera. I don't know.
Spot on. Kira, you can sign up for ophthalmology training after this lecture's finished. It's actually, you're absolutely right. The risk factor is sun exposure, and it is a fleshy thickening that starts over the conjunctiva of the bulbar conjunctiva and spreads across the cornea and can encroach on the visual axis. You know, the middle bit, the pupil of your eye where the light goes into the retina, it can cover that. And as it's growing, even before it covers it, it can distort the cornea, which, as I mentioned to you before, is this beautiful, pristine structure responsible for 2/3 of your focusing power. You can imagine if you've got a big, lumpy, fleshy bit sitting on top of it, it can distort your vision. And somebody mentioned astigmatism earlier. It can cause astigmatism. It can cause other refractive errors. And when it encroaches fully across the visual axis, well, you can't see through it. And as I mentioned, the risk factor, and as you mentioned, Kira, it's sun exposure. In rural and remote settings, in the rural and remote settings that I've worked in at least, they're sunny environments. Fiji is a very sunny environment. That's why people go there for a holiday from all around the world. But unfortunately, the sun is also can be very damaging to the eye. So pterygium, and I've seen the worst pterygiums I've ever seen in Fiji and in India as well. It's just unchecked. You know, people don't realize that it's a problem because they've got the other eye that's working all right. So they carry on with their farming and whatever else they're doing. And they see us in clinic and we go, hey, you know, maybe they might see us for something else. And we'll say, hey, look, that thing needs attending to. And look, Kira says, I have a lot of white water kayaker friends with pterygium. There you go. There you go. So it's you know, you might say that's a first world problem, but the sun doesn't differentiate between somebody kayaking and somebody working on the farm or somebody who's a construction worker. It just affects everybody equally. It's a great level of the sun. And glare off the water, no sunglasses. Absolutely correct. And I would just, as a public health tip, sunglasses always, and make sure that the sunglasses cut off, try to, as much as possible, try to cut off the glare from the side as well, because you can get on snow, you know, on when you go skiing on snow and off water, you can get reflections coming in through the side of your eye. And hat, always, and sunscreen. You know, these are the things that are just standard things. But a lot of people in these settings where I'm discussing today, they don't have access to sunglasses, simple things like sunglasses. They might have a hat, but sunscreen, what's that? Even people with, you know, pigmented skin, darkly pigmented skin, they get pterygium, of course. You know, they get sunburned as well, but do they have access to these things which mitigate the effects of the harsh sun, of UV radiation? No. So it's a real double whammy. They're out there, their lifestyle is that they're out there in the sun and they don't have those simple things which protect them. And now I want to shift into talking a little bit about the inequities that are there in eye disease. We find that across the world, age is a risk factor for developing various eye conditions. In high-income settings, indigenous peoples and ethnic minorities have a higher prevalence of eye diseases or vision impairment. And socioeconomic status, regardless of where in the world or which society you are, if you are of poor socioeconomic status, you're at higher risk. And here's the other inequity. 55% of visually impaired people are women. There are 50% of the population, global population, and they bear a higher burden of vision impairment. Why is that? Maybe it's something we can think about. And that almost 90% of visually impaired people live in low and middle income countries. And these countries are in Asia, sub-Saharan Africa, in Oceania, which we otherwise call the Pacific, and Andean America. In these countries, the burden of eye disease is significantly higher than in other places. So there are inequities. You know, the numbers that are presented in the previous slide don't tell the full story. And that's like that in medicine and in healthcare. The numbers won't tell the whole story. You might measure a blood pressure, for example. You might take a pulse, you might take an EKG. But does that tell you the whole story? You actually have to talk to the person in front of you and get more dimensions of the story. Sometimes you have to talk to their relatives, their carers. Sometimes you might have to go and see the context in which they live to get a clearer picture, and then you can help them. You're a better chance of helping them. If you just treat the numbers, I think you'll not be able to help them fully. That's been my experience in medicine anyway. These are a few photos of patients that were taken with their permission and shared with their permission from the various medical camps that I participated in Fiji. And on the left is an Indo-Fijian. In Fiji, the two main populations are the indigenous, and the lady on the right is an indigenous or Itoke lady, and the lady on the left is an Indo-Fijian. In other words, our forefathers came from Britain, brought over by the British to work in Fiji as indentured laborers. Some people, some historians characterize it as slave labor. Certainly there are, suggestions that it wasn't all well thought out and fair employment conditions, let's put it that way. I don't want to be controversial here. So the lady on the left is the mum of one of my very good mates who attended one of these camps that we did. And she's a widow, so she's wearing a white sari. And the lady on the right, I just put that there to show you some of the differences between the cultures. And this is to highlight that, that females bear a greater burden of vision impairment. And this has been shown by the data by these two studies that I've cited here. The interesting point is that a higher proportion in the Dutoit et al. Study, that a higher proportion of females reported eye problems, and a higher proportion had bilateral vision impairment. However, males and females accessed eye health care nearly equally. In other words, females might have more eye issues and they might have more serious issues because they got bilateral impairment, but they tend to present equally, generally equally. So it's another thinking point for us. We've also found that there is inequity in terms of being illiterate, being migrants, person with certain disabilities, and in rural communities. And the photos on the right are from some of the rural settings in which we have done medical camps and eye camps in Fiji. It's beautiful countryside. If you look at the top right-hand picture, it's people playing rugby there. It's just beautiful mountains. It's just lovely. But it's just idyllic. But the standard of healthcare is very poor. And they bear, those rural communities, they bear a greater burden of disease. And you can see this ocean in those, top left-hand and top right-hand corner there of the ocean. So they live on islands that are, and where are the ophthalmologists? Where is the gear? Where are the operating theaters? Where are the laser gear? They're all on the main island. So you'd have to think twice, 3 times, 10 times before you got on a boat, which would cost you a lot of money before you got to a good standard of eye health care. And so rurality is a risk factor, and rural people bear a greater burden of eye disease. However, here is the irony. Rural dwellers expressed satisfaction with their vision despite being more likely to regard it as limiting their activities and being less likely to seek conventional care. Something I might touch on a little bit later, this conventional care point. So they acknowledge that, yes, it is affecting me, but I'm okay, I'm happy with it. Now, that could speak to the stoicism of people who live in rural and remote communities. And, you know, one of my heroes is, well, heroes, I don't know, heroes might be a strong word, but one of the guys I really love watching on YouTube is Dr. Glockenflecken. And he does some great videos on the stoicism of people in rural and remote settings in America. And I think those features that he parodies in those videos, certainly it's no laughing matter, because in reality, that's true. That's been my experience of people from rural and remote settings. They just carry on. You know, they might have one eye and the other eye is so badly damaged, but they just carry on. And that's an inspirational thing as well. You know, you see that and think, my goodness, how could a human being have so much resilience in them? But there are people like that in the world. Who knows what this is? Any idea? Any thoughts on what this might be? Hemorrhage? Yes, good thought, Ani. PRP, Sam, nailed it. It's PRP, which laser scars, absolutely, well done. Because Sam, when you do PRP, somebody will say, a patient will say to you, what is PRP? And you need to have layperson's language to be able to explain them. Yes, they're laser scars, and they have been applied to a patient with either severe non-proliferative diabetic retinopathy or proliferative diabetic retinopathy. And I suspect it is the latter, as Ani has hinted. Perhaps they had hemorrhages before in the retina. There's certainly signs there that there's some neovascularization. In other words, new vessels that grow in response to ocular ischemia. And as you know, diabetes, or as you may know, diabetes is a disease of blood vessels, of small, moderate, and sometimes large blood vessels. So when those blood vessels, the blood supply is impaired, there's ocular ischemia and new vessels grow in response to that. New vessels are more friable than the ones that were there at the beginning, that came with you from the embryo. And they tend to bleed. And so to reduce the metabolic demand of the retina, we apply laser panretinal photocoagulation, which in a sense is actually killing neuroretinal tissue. So if we ablate that tissue, then it won't need oxygen and blood supply, and therefore it won't feel the need to drive new vessel growth. So yes, it is panretinal photocoagulation, and generally it's used as a prophylactic thing, sometimes a treatment thing in diabetic retinopathy. We spare the central part of vision. You can see in the middle there, that's your macula, or this patient's macula, and there's no PRP scars there because that's responsible, as I mentioned to you earlier, for central vision. Really, there's some study findings here, but essentially what these study findings tell us is that diabetes is worse in Fiji Indians who are age matched to their Sydney or Australian counterparts, that they present later with worse disease. Why is that the case? Again, things to think about. Why is diabetes on the rise in places like Fiji? This is what I observed. Now, as I mentioned, I grew up in Fiji. And so, 40, 50 years ago, what was the diet of people? What was the lifestyle of people? There's been a transition, and it's palpable. You can see it on the streets. This transition from traditional diets to a more Western diet, processed food, high fat, high sugar. Now, anyone want to have a guess at the sort of vegetables and items that we're seeing? This is at Suva Market, just on the street there, on the footpath, on the pavement. A street vendor or this lady has set up her stall. Anyone hazard a guess at any of the vegetables and fruits that you're seeing there? Maybe not something you might see in your supermarkets in America or in Australia. Yeah, some root vegetables, 100% correct, Tamika. There are some root vegetables, those things in brown. Yeah, yams, taro, 100%. They are certainly there. there's definitely yams there, and there's some cassava or tapioca. You'll find this in Africa. You'll find this in in Asia, and all over Oceania. These root crops, and so these are the staple. This is what provides the carbohydrate and the starch in diet. Low GI. And there are eggplants, those purple things in the Fiji are not in Fiji. We don't really have Fiji common. We have guavas there. There are probably some lemons. There are some pawpaws there. I don't know if you can see my cursor. There's some green. There are some fresh chilies here, and this here, the purple in the foreground, are eggplants. Beautiful, eggplants, lovely. You can roast them, you can curry them, you can do anything, you can bake them. They're just lovely. Yeah, absolutely, you're right, Tomika. It is absolutely delicious, and you can prepare it in 100 ways. What you grow, you cook, you prepare, you eat, and it's absolutely very low preservative stuff and very low other additives. Just delicious, and access to it. But now what's happening? Guys, on the right-hand side, there's a cell phone shaped like a biscuit shaped like a cell phone, for heaven's sakes. Jackie Chan, the Hollywood hero. I didn't know that he moved to Fiji and opened a fast food joint that says Jackie Chan fast food. And of course, ubiquitous Coca-Cola everywhere. So they seem to be popping up all over the place, these fast food places. So the transition from a traditional diet to a more processed Western diet is driving the burgeoning burden of diseases like hypertension, or conditions like hypertension and diabetes. What are some of the, let me just see how I'm going for time, etc. Okay, some of the barriers to accessing healthcare. So I've grouped them into attitudinal factors that, they prioritize and say, well, what's really important? I'll just go and see my doctors about that. And as I mentioned earlier, they kind of people tend to accept. And I have seen so many patients who've said to me, oh, well, why didn't you come earlier, sir or madam? Why didn't you come earlier? This is so far advanced. This disease, this diabetes in your eye is so bad. This cataract is so bad. This pterygium is so bad. Why did you come now? Why not earlier? Oh, well, I was managing all right. I was doing my work. It was okay. And I had the other eye, and they'll say things like, oh, there are lots more people who are much worse than me. Oh, I didn't want to waste your time. Come here and sit down here. You've got many more important people to see, people with worse conditions than I. People say these things. Or this fatalistic attitude. I thought nothing could be done. When we did camps in India, people would say, oh, it's my karma. Or what we'd say, in English, my karma. I was due for this, so it came, so I'm accepting it. Things like that. And then there are also, factors like their location, their age, their income, not being able to afford medications. Number of patients, I've just lost count of the number of patients where you'd start them on drops for, say, something like glaucoma, or antibiotic drops for an infection in the eye. And they come back for a review. If they come back, sometimes we don't even see them. They come back for a review. What drops are you using? Oh, nothing. What happened to the drops I gave you? Well, they ran out. Didn't you get a fresh set or a fresh vial or a drop? No, why not? Couldn't afford it. Or the pharmacy is too far away, or the boat wasn't due for another 2 weeks to come to our island. So I thought I'd be fine, but I felt okay. But as your eye was feeling okay, it was actually being damaged from inside. These are the sorts of real factors that come into play. And this sort of thing. It says here, Vinco's cataract drops for oral use only. I confiscated this from a patient. I said to them, sir, you've got cataracts. And he said, that's impossible. I said, why is that? He said, because I take cataract drops. The sheer ludicrousness, is that even a word? I don't know. The ridiculous. It says cataract drops and it says oral use only. Drops are things generally that you put in ears or in eyes, but it's for oral use. It's probably not a drop. There's probably a vaccine that's a drop, but that's about it. and it says here, aids in resolving cataracts of various origins. Cataracts can be formed from age, from inflammation, from trauma, from certain medications like steroids. So this particular preparation says it aids in resolving cataracts regardless of the origin. Now that should raise an alarm bell in us as healthcare professionals or budding healthcare professionals, because we always say, let's look at the cause of something. But this makes the claim, regardless of the cause, I'll dissolve it. I'll resolve your cataracts for you. And look down the bottom, guys, contains 20% alcohol. Homeopathic drops, 20% alcohol for oral use. You know, that's stronger than most beers. I mean, this is the sort of thing that I have seen in my career. Like I said, this is from a patient that I confiscated. And you can look at this. You live on an island. There is the ship that we came on, actually. And between an eye hospital and you is the expanse of Pacific Ocean. And these patients came in these little dinghies with outboard motors. And so the village headman had arranged for these dinghies to ferry outboard motor powered boats, punts, to ferry villagers to our camp because they heard we were around. So boatload after boatload of patients arrived. So you can see this is how we access higher level healthcare. If we have eye problems, we'll be very reluctant because it costs money. You know, you've got to pay somebody to take you. Of course, if you have natural disasters, on the left, I took this photo in Cyclone Winston in 2016. It's a house with a roof completely blown off and trees a mess all around. So, you know, if your house doesn't have a roof, you don't have drinking water, you don't have access because your roads are blocked off. What are you going to do? Say in this cyclone, if you had a traumatic eye injury, if you had a blunt trauma from bits of timber flying around or branches flying around, you happen to get caught in the wrong place at the wrong time. You've got eye trauma, you can't even make it to an eye hospital where you need definitive surgery or treatment. Floods are a common thing in Fiji. Every cyclone season, in fact, I had a student email me a couple of weeks ago here at UQ saying, hey, Dr. Reddy, we're thinking of going to Fiji. Is this a good time? And I said, you're going in the cyclone season, think twice. Because with cyclones, we have floods, we have landslides. And this is the main street of one of the towns on the island where I'm from. And it's absolutely flooded, as you can see, and not a soul to be seen, rightly so. And above, on the first floor there are actually apartments. At the ground floor, there are shops. So shops, apartments, roads, everything is affected. How will you get to eye health professionals? So here are some of the challenges as far as I can see. Having good ophthalmologists and eye health care workers on the ground. We lack subspecialist opinion. Showed you a picture of a retina with PRP scars. Vitreoretinal surgeon is not resident in Fiji. They have to go, anyone who needs vitreoretinal surgery will either have to wait for the subspecialist who comes once a year or put together some money and go overseas, Australia, New Zealand, India maybe, to get that treatment. In terms of pathology and imaging services, you know, specialist medications, for example, or treatments, uveitis treatment for immunosuppression, all of that is just absent. So which means that you get more untreated and more severe disease. Equipment, you know, either you have it or you don't have it, or you have it, but you can't service or maintain it. There's a role, you know, very significant role for tribal healers as well. As I mentioned in one of my earlier slides, that a lot of people choose tribal healing. In Australia, we might call it bush medicine. You know, so they would choose that because it's more accessible. It's there in their village, rather than have to get in a boat or catch several buses and go to an eye hospital. There is a disparity in the quality of service, the resourcing from the government point of view versus non-government organizations like Fred Hollows that I worked for. So as a result, private operators are stepping into the breach, and there is now a boom of private health services in Fiji for cardiology and various other services, and for vision as well. There are non-government organizations that come in, but coordination, who's doing what? You know, somebody comes in, does a bunch of cataract operations and disappears. And then the next lot comes in of non-government organization and says, we've come here to do cataract operations to this village. Oh, but somebody was here last week and they've sorted us out. So coordination between these services. And this is, again, something that you may find in other wilderness or rural and remote settings. Affordability, people just don't have the money to access the overseas, the care that's available overseas. And like I mentioned, physical access is very poor. There are lots of people who are giving hope. Lots of non-government organizations, specialty college like Bransco, who are really trying to do everything they can to reduce the burden of eye disease in Fiji and in other places around the world. In fact, when I was there in 2015, there was an American Navy ship, a floating hospital that docked and went around some of the islands in Fiji, and a fully equipped hospital, and they had an eye operating theater as well, and an eye room in there, lasers, the whole works. And that was an initiative from the US government to, I guess it's what they call soft diplomacy, helping the communities with the resources that they have. So there are lots of examples like that. And these are examples of some photos of some of my wonderful colleagues whom I worked with in Fiji and played a very small part in helping train them. In the blue shirt in the middle there is Dr. Duke Mataka, who's the first fully trained ophthalmologist in the Kingdom of Tonga. And on the right-hand side is Dr. Nola Pikacha, and next to her is Dr. Mundi, and they are ophthalmologists from the Solomon Islands. Down the bottom is Dr. Haris Ansari, who came all the way from Pakistan to work in Fiji. And the bottom picture there that, on the boat is Dr. John Setu, who was the first ophthalmologist in the Solomon Islands. And you look at him, he's just got a singlet on and a cap, and he's going on a boat. They're actually going to do outreach. If you look at him, you won't know that he's such an experienced and amazing and esteemed ophthalmologist. But these are some of the wonderful, wonderful people that I've worked with and who continue to do yeoman service, just dedicated, determined service to their people. And just a few things in conclusion, some sharing of my experiences. One of my mentors once said to me, if you don't like the sight of, a waiting room heaving with humanity, don't do ophthalmology, because wherever you go, your waiting room will always be full. And so this is one of the camps that we did where, just everywhere you can just see people, they're sitting everywhere they can, standing room only, waiting to be seen. The other thing is people are just so grateful. The fact that you've taken the trouble to come out and do your little bit to help them, then they feed you like anything. They really look after you. And so this was just a note to self to remind myself of just how beautiful the people are, how grateful they are to us. And there's some beautiful fruits there, some guavas and pawpaws there, and mandarins, locally grown, of course, and some sugar there as well to go with your tea, diabetes on one side and traditional foods on the other side. And here's us enjoying some of that wonderful food there, having a break. And here's one of my other good colleagues who now practices in Sydney, Mr. Keaton Daya, who's an optometrist. And the lights have gone out, the lights are on in the room, but outside it's dark. And this is just to show us that there are some dedicated, committed people who will just work regardless of the conditions. The windows are open, mosquitoes are teeming in. That's one thing you don't see. But Keaton just keeps going. And that's kind of the spirit that you get, when you work in these environments. You see people who are next to you, and they inspire you, and you just keep going, and you try to give the best to the people that you've got in front of you. And here's me examining a fundus or a retina of this patient. These are the lessons that I learned, and I just wanted to share them in summary with you. All over the world, there are low and middle income countries. There are people living there. Through some circumstance, they are there. But they don't deserve low and middle level service. They might be in countries which are designated as such, but they don't deserve that. And so I feel I must do everything I can to help those people. The other thing I learned was not to sort of have this angel mentality, I fly in like an angel and I fix everything and I fly back out again on my wings. but rather to work with local colleagues. And if possible, build capacity, something that I can offer you. You know, can I do that? And I'll learn something from you. Now let's learn from each other. So really work with local colleagues to build up capacity. The other thing I learned was public health is important. And as Nate mentioned in my introduction when he introduced me, that I did a master's in public health and now I'm doing a PhD in public health. Because I really felt and feel that there was a bit of a gap in my medical training, that public health is critically important, but we might not have as much exposure to it. We get, you know, the glamour of hospital medicine, you know, everyone clear, you know, and you defibrillate people, that sort of thing, you know, sirens wailing and gurneys or trolleys being wheeled in, and high-tech equipment. We think all of that is important. And guess what? All of that is actually public health. Somebody's got to pay for it. It is important. I wish I'd paid more attention to public health in medical school, but I'm hoping to address that by doing further study. And the people that you serve are really yours. I've seen people, I've treated people who I thought, gosh, that's just like my auntie. You know, this lady is just like my sister or cousin of mine. You see a lot of your life in these people. The only difference is you've come from somewhere else, they are from somewhere else. And that's again a note to self, prepare well from this moment on. In other words, we shouldn't think that, oh, at some point, I'm going to get into this stuff. You guys, you know, the 20 of you that are here, 17 of you that are here, you obviously made a decision that this area of medicine interests me. I want my vision to be opened up. I want to look beyond my grades and my, you know, my little medical degree or my healthcare degree. And so I must do the best I can, because the lady I'm treating in a village in Fiji, some remote village, doesn't know that this guy didn't pay attention in medical school. She just expects to be helped. She just wants to be helped. So don't waste this moment. Seize the day. Really do seize it. And, you know, a lot of these camps we've done for service, but there is an I in service. In other words, it really does benefit, or it has benefited me. Ostensibly, I'm doing it to help other people, but actually, it helps me because it serves my soul. It makes me feel as if the hundreds and thousands of dollars worth of investment that somebody has made in me is actually being well spent, or is being well used to help people. You know? So that makes you feel good in medicine. You know, we do it because we want to actually be of use to people. And so this work in Fiji and in India has really brought that home to me. When I was doing one of these camps, somebody took a photo of me and turned it into a, I had hair back then. And it says, if you have the power to make someone happy, do it. The world needs more of that. And they turned it into a poster for a mental health campaign. So really, if we have the power to do some good, to help someone, do it. And where's the hope? Is people who prepare themselves well in clinical science and learn the pathologies as learn the pathologies well, the science, the biomedical science as well, who know, are proficient, who practice how to be good healthcare professionals in taking histories and diagnosis and in treatment in management plans, who are actually interested in public health and do that properly too, because all of this is public health. The epidemiology, the biostats, the data that I shared, the actual delivery of healthcare. And there are loads of equity issues. So ethics is really important. Where is the hope? It's in people with a heart of compassion, a mind and body, which is coursing with clinical competence. You can't have compassion without competence. There's a great writer and another hero of mine, Stephen Tresiak, out of New Jersey, who says this, and I really hold this to be true. People with a heart of compassion, a mind and body of clinical competence, and a will of conviction and courage. There's a lot of C's there. I think it takes a will. And your organizers, your board, have already demonstrated that by having an organization called GOMI to imbue people like yourselves with that conviction and courage to say, go where it's not easy. Go where everything is not shiny. Go where you'll have to break a sweat. Your hair will be dusty. Your scrubs might get torn because you're trying to carry equipment and you've caught it on a nail that's been sticking out where you're practicing medicine. Go there. Go there. Be that person. Be that guy. Vinaka Vakalevo, as we say in Fiji, thank you very much. And here are my references.
Well, thank you, Dr. Reddy. Sometimes these talks leave me with more motivation. This was definitely one of those talks. I feel ready to, for me, go back in the library, but really remember, why we're doing this stuff. So thank you so much for sharing your experiences. And this was a great opportunity to not only finally see ophthalmology in the wilderness medicine setting, but to just see some of the really great applications that you've made in your career.
Nate, to learn about this stuff is very fulfilling, very thrilling. To practice this stuff, to get better at it, is a higher level. To actually do it with some level of competency and help people, that's a higher level still. But then to share it with people like yourself and your colleagues here from different parts of America and maybe different parts of the world, well, that's just next level. To be able to share it with people like yourselves really gives me so much joy that I can't put in words.
Yeah. Well, it has been just about an hour, so if people have to log off, feel free.
I'm happy to hang around for a couple of minutes if anybody's got comments or questions.
Okay. Yeah, if anyone does have any questions for Dr. Reddy, you can put them in the chat, or you can take the brave step to show your video and unmute yourself. Either works. I actually have a question for you, Dr. Reddy.
Sure.
I want to know what you're doing in Nepal. Specifically, what sort of things have you found? What's your project turning into over there?
Yeah, great question. Really, I'm looking at the climate resilience of the Nepal health system. And Nepal is one of the most climate vulnerable countries in the world. They have, glacial floods. They have ordinary floods. They have it's just crazy. And so are their health systems ready? Are they resilient to these challenges that climate change is already giving them? So I'm really looking at the health system as a whole to see assess where the gaps are, where the strengths are. And so to do that, I guess in terms of methods, I've interviewed a whole bunch of stakeholders in the Nepal health system. I've visited a number of facilities, and so pulling that all together into a PhD research.
Nice. I've actually been there twice now.
Yeah.
I have not done a PhD project there, but are you mostly in the Kathmandu area, or are you going out to some of the rural areas?
Kathmandu.
Okay.
Kathmandu.
Great.
Yeah.
That's great.
Katrina, good question. What is the most useful tool to have in remote regions, wilderness, for eye pathologies? Well, that's a very good question. You said tool, so I'll say one word. It's not plural; it's singular. I would say a direct ophthalmoscope would be the most useful single tool. And of course, the training to be able to use that. Direct ophthalmoscope, you can use it to illumine the anterior segment of the eye. And with a slit beam, for example, the slit beam setting, you can look at the anterior chamber as well. So you'll get a good idea of the front of the eye, the cornea, some idea of it. And then, you could have a look through hopefully a dilated pupil into the retina as well. And so probably the most useful tool, I'd say, is an direct ophthalmoscope, something you can keep in your pocket, make sure it's well charged, and you can take it with you wherever you go. If you are allowed more gear, I'd say a Snellen chart or a vision chart, which you can roll up and keep in your pocket as well, just to give you some idea as to how bad vision is. And of course, the Snellen chart should be appropriate for the setting that you're going into. There's no point me having, with the letters, English alphabet, in a place which doesn't speak English. So something that's appropriate for that. So maybe those two things I'd say would be useful. But if I had one choice, Katrina, I'd say probably the direct ophthalmoscope. Illumination and magnification are key in ophthalmology. So that tool provides you with both of those.
We've got a chat question from Sam, wondering if
Oh,
you've
yes.
ever worked with that
Excellent
project.
question. Absolutely. And Jeff Tabin, I never met the guy, but a hero and a legend. Absolutely. I've never worked in the Himalayan Cataract Project, Sam, but as you've said, Jeff Tabin is a pretty neat guy and he's built an impressive organization there to improve vision for folks. 100% agree with you. And I mentioned Professor Fred Hollows. He was one of my heroes, still is, although he is passed away. But Jeff Tabin, another one of those amazing individuals who've just done such good work, you know. And people like Fred Hollows and Jeff Tabin, they're trained in this environment, you know, with the best possible gear, with everything, you know, first world where we are training. And they took that to the places that didn't have it and tried to give them, you know, world's best care, or as close to it as possible. That's what I meant when I said, you know, those people, they live in low and middle countries, but they don't deserve low and middle level service. Great comment, Sam. Appreciate it. Karina, really good question as well.
All right. Looks like that might be it for questions. So with that, I think we'll call it. Dr. Reddy, thank you again so much for dedicating this hour. It was great. And to everyone else, we'll be back in 2 weeks for a presentation on disaster medicine.
I wish you all the best with the remaining lectures, Nate and colleagues. And thank you very much for inviting me. Thank you very much for you know, being such a wonderful interactive group of participants as well. I've really enjoyed this last hour or so. I'm very, very happy to have contributed in a small way to your journey.
Great. Thanks all. Take care.
Well, have a wonderful evening. Thank you.